Thank you all for having me here today, and especially Anne for coordinating all of this. This is not an easy task. It's a pleasure to be in Southern California. I actually was just looking at a quote from Joan Rivers, and she said, I'm modifying it a little bit to be a little bit more PC, but she said, people in California are so great because they're so health conscious. But the problem is they don't believe you're sick till you lose your tan. So hopefully that's not the case, but I will be talking a lot about symptoms today, and because sometimes you can feel very, very sick, but you may not even outwardly portray it. But we know that people with MPNs can have pretty severe symptom burden. So I'm going to talk about that. Then I'm also going to talk about how some of our research has delved into some of the differences in genders between MPN types. And I'm going to talk a little bit about sexual dysfunction, because that was one of the questions that someone had originally wanted to be addressed. So bear with me while we talk. And I do hope, the number one thing I hope you come away from this talk with is some really great ideas on how to deal with symptoms, but especially fatigue, because fatigue is the number one symptom. It's in women, it's actually higher in women than it is in men, and it's something that can really disable your life. All right, so what are we going to talk about? Exactly what I talked about just a second ago. We're going to be talking about symptoms, especially with a focus on fatigue, some of the gender differences, and sexual dysfunction. Oh, sorry. So to talk a little bit about the natural history of MPNs, and this actually goes into a question that you kind of asked a little bit earlier. So what is an MPN? Well, it all relates back to the blood, and this is new data that's come out. It's actually been out for a little while, but we're discovering more and more. Up to a third, and this is most easily looked at women, to a third of women will have, by age 65, something called clonal hematopoiesis, where until recently we weren't really able to screen for this very well, but we can see that most of their blood comes from one source. So basically there's one stem cell that's growing, but we won't pick up on it as a physician in our clinical duties, because these people don't have abnormal blood counts. And even the bone marrow can look normal. But over time, what they have seen is that these women most often will have the same mutations or DNA changes of women with MPN, except that women with MPN will tend to have more and more aggressive mutations. So when you look over time, you can kind of think of it as a continuum where you see increased rates of secondary events, be it thrombosis or like blood clots or other malignancies. And you see over time some decrease in the normal blood production in the body as these mutations pick up. At first, for essential thrombocythemia and polycythemia vera, you will actually have mutations that will cause the blood cells to basically grow too much. And then with myelofibrosis, those blood cells basically lose the ability to produce as much, and you start to get lower blood counts. And this can predispose to progression to acute leukemia, which can be very aggressive. And again, then you can see very high blood counts, but sometimes you can actually see low blood counts. And the high blood counts are usually blasts, and you don't want those. So most of my previous work has looked at symptom burden in MPNs. So this is actually kind of a pretty way to look at it. So the bigger the word is, the more prevalent it is. So fatigue is by far the most prevalent and severe symptom that MPN patients will face. Other bad symptoms include dizziness, problems sleeping, loss of quality of life. They can have sexual problems, numbness, tingling, depression. They can get full very fast. They can get abdominal pain and abdominal discomfort, problems with inactivity, problems with itching, depression. They can have weight loss, night sweats, headaches, cough. They can have other mood problems other than just depression. But there's a whole constellation of symptoms that we've been able to identify in MPN patients that make, overall, their lives a lot harder. Part of my previous work, too, has been to work very closely with Dr. Robyn Mesa, who's one of my very dear friends and wonderful mentor for me. So with him, we went on to actually develop what we call the MPN-10. And so this is a symptom assessment form that we use in the office and has actually now been included in the large guidelines for cancer patients called the National Comprehensive Cancer Network, or the NCCN guidelines. So we actually recommend that for myelofibrosis patients especially, but there's also a good role in polycythemia vera and essential thrombocythemia. But to take a look at symptoms, especially initially, and then in response to treatment. And with drugs like ruxolitinib, we can actually see a significant decrease in symptom burden over time. And this assessment tool has been what's used in the large trials, especially most of the trials that are coming out now, to look at symptom burden. We know that symptoms are very important, not just from a quality of life perspective and from a functionality perspective, but also, especially for myelofibrosis, they're actually associated when symptoms get worse, people tend not to live as long, and they're what we call prognostic. So we've done a lot of work too in what do the symptoms stem from in the myeloproliferative neoplasms. So we know that they can stem from vascular events, so things like blood clots, bleeding, elevated blood counts. You can get blood clots, especially blood clots in the abdomen. A lot of times people tend to be very symptomatic of that. The low blood counts, especially in myelofibrosis, can cause problems with symptoms. You can also run into problems with blood counts needing transfusions. You can get symptoms from the transfusions. You can get medication-related symptoms versus just from the disease itself. Progression can cause symptoms, especially we know that myelofibrosis is much more symptomatic compared to polycythemia vera, which is more symptomatic than essential thrombocythemia. Organ dysfunction in general, so when your spleen gets very big, that can be extremely symptomatic and can push on other organs, cause you to get full very fast, cause you to feel uncomfortable when you sit down or when you bend over to pick something up. You can have blood production outside of even the bone marrow or the spleen. You can get blood production in the liver and the lungs that can cause symptoms. You can get inflammation-related symptoms, and so these are things like fevers or chills or night sweats and general fatigue from that too. You also can have problems concentrating on a day-to-day basis. And then you put all of these ideas into the concept of that we are more than just a diagnosis, but we come in the background of potentially other diagnoses that come with this, and then how old you are kind of affects what your reserves are. You can, have psychological issues to begin with. I mean, you could be in a bad situation where there's a lot of stress in your life. You could be on other medications that can affect symptom burden, as well as even nutritional status. So we know that nutrition is an issue in MPNs. A lot of them, especially in myelofibrosis, a lot of MPN patients can have low cholesterol levels, and that's actually that's associated with worsened overall survival. But there's a lot of different parts of this that can affect symptom burden. So I'm going to focus on the most pertinent symptom as well as the most severe, which is fatigue. So what is fatigue? I'm sure, you guys don't have to do this, but how many of you have dealt with fatigue recently as a problem? Yeah, that's about right. There's many different names and descriptions of fatigue. In the dictionary, it's an extreme tiredness, typically resulting from mental or physical exertion or illness. But, a lot of times we'll describe it as exhaustion, just feeling really lethargic or worn out, feeling just weary. It just can't go on. Medically speaking, when you go to your doctor and tell you you're fatigued, they should hopefully try to tease out what is fatigue and what is something else that might feel like fatigue. And this could be something like shortness of breath, or just not getting enough sleep, having problems sleeping. Even lightheadedness or dizziness is sometimes described as fatigue, but it's a little bit different. We know in MPN patients that over 90% are affected by fatigue. And this can affect quality of time with your loved ones. You have less energy to do things that you would normally do on a day-to-day basis. Working becomes so much harder. If you're spending more and more time inside the house, which can affect mood as well as just general outlook on life. You can spend less time being able to sleep well, less time at work, which ultimately means probably more stress with finances. We've done some other analysis, and kind of a fancy way that we say this is that there's a loss of role, social, and physical functioning that can happen with fatigue, and that we see more commonly than in the general population in MPN patients. So fatigue itself, we've talked about the different etiologies of different symptoms in MPNs, but fatigue itself, so the symptoms alone can cause fatigue, or and be etiologies with it. So you can get the fatigue, fevers, night sweats. Nutritional deficiencies can cause fatigue because you need these resources, and your body's actually, with the MPN, using them up faster. You can get the low blood counts that cause fatigue, and your body doesn't have enough ability to even bring oxygen around to the tissues when you get very anemic. You can get cognitive dysfunction that can cause fatigue, and there's been some interesting data that with inflammation, potentially inflammation related with the myeloproliferative neoplasms, that you can actually get some inflammation that crosses the blood-brain barrier and goes into the brain, causing the cognitive dysfunction. And then you can even get cancer growth that ultimately makes you feel more fatigued. So we did a large survey. This was a couple years ago now. Almost 1,800 people, just like you, responded to our survey online. It was inordinately long. That's the one caveat I give it. It was 70 items. Overall, 93% of patients had reported that their fatigue was, on average, severe. Again, fatigue negatively impacted aspirations, travel plans, long-term planning, vacation planning, and that in the majority of patients as well, it was so bad it limited their normal daily activity. In the future slides, if you see a box on the right, those are the amount of, so I'm going to give you some ideas on what patients reported that they did to help alleviate fatigue. I'm going to give you the number of patients, or the percentage of patients that attempted it, like this intervention, and the number that felt it to be successful. So when you see that box, it's referring back to this survey. And now I'm going to give you some ideas of different things that can contribute to fatigue and things that people can do about it. So we asked in this large survey, so what other medical problems people had that would be potentially related to fatigue? We were able to see a large proportion of patients had these other medical illnesses, and these can include things like low thyroid function. They can get restless legs at night, and that a lot of times will come with iron deficiency or low blood counts. You can get heart failure that makes you feel very fatigued. Sleep apnea can cause fatigue. Other inflammatory disorders like rheumatologic disorders can cause fatigue. Diabetes can, fibromyalgia, chronic lung diseases, chronic fatigue syndrome, which is actually a thing, chronic kidney disease, and chronic liver disease. When we looked at their fatigue scores, out of all of these other illnesses that patients had at relatively high proportions, we were able to see that restless leg syndrome, diabetes, fibromyalgia, and chronic fatigue syndrome, as well as chronic kidney disease, were significantly associated with worsened symptom, worsened fatigue scores. We also looked at medications that can cause fatigue. And again, MPN patients are usually on there's a pretty high frequency of patients that are on medications that might contribute to fatigue, and this can include blood pressure medications, antidepressants, antihistamines, anti-anxiety medications, prescription pain medications, steroids, cough or cold medications. And again, in these, the most significant ones that we could see that were actually associated with the worsened fatigue score were antidepressants, antihistamines, anti-anxiety medications, and prescription pain medications. Mood is another thing that, kind of as I alluded to before, is something that can really impact fatigue. Around 23% of patients in this study actually scored very high on the scoring mechanism that we used to help. Basically, it was indicative that they probably had underlying depression. We know that in general, blood cancer patients are at very high risk of depression, especially with stress in your life. It can actually cause a flight or fight response. So we use fancy terms. There's the sympathetic and the parasympathetic system, but the sympathetic system makes you, basically it's when you get nervous or you're up here for a talk or something, your heart starts to race. But that actually takes energy from your body, and that stress can actually cause you to be more fatigued, especially when things start settling down. So you're seeing a lot of times when patients are at work and stuff, they might feel okay, but as soon as you get home, you just cannot get off the couch. We know that vitamin deficiencies in nutrition have a lot to do with fatigue potentially as well. We know that the gut is a critical organ in blood cancers. It deals a lot with how our body responds to the outside world. There's a lot of data in terms of microbiome and basically the bacteria that are in the gut and how that affects especially cancers in general, but that was one thing we're actually looking into, is how that might affect blood, or MPNs in general, blood cancers. We know that sometimes even therapies that people are on can affect the absorption and metabolism of foods that we eat. And this becomes very relevant when we get into foods that are important for blood production and vitamins that are important for blood production like vitamin B12 and folate. Vitamin D is a notorious one, or vitamin that when it gets low can make you feel very fatigued. The other thing is kind of what I talked about before in terms of nutrition. Myelofibrosis patients especially are at higher risk of weight loss. And that weight loss over 10% over 6 months can be associated with worsened overall survival. So it's something to keep a close eye on. If you're losing weight, you definitely should talk to your physician. Exercise is something that we ask patients about, and this is where you're going to start to see the little red boxes that we asked if people had attempted it and what percentage of people felt that it was successful. Exercise is very unique. Out of everything that we asked people about on this very long survey, it's the only one that showed what we call a dose-response relationship, where we asked people about it. The more that they did it, we could actually see incrementally the better they felt. So you could argue that maybe it's a little bit of a chicken or egg. Are they feeling better because they exercise more, or do they exercise more because they feel better? But regardless, there definitely seems to be some sort of relationship here between exercise and fatigue. Around 73% of people did exercise on a regular basis. Around 63% of patients felt it was successful. Sleeping habits, so these are some interventions you can use to help deal with fatigue. Sleeping habits are very important. If you're dealing with fatigue, what I would recommend are regular bedtimes. Avoid large meals up to 2 hours before bed, and this becomes very pertinent for people with large spleens, but they're going to have a lot of pressure already on their stomach. When they lie down, it's going to start to get more and more uncomfortable to lie down, and you're going to be at much higher risk of acid reflux coming back up. If you are dealing with problems with going to sleep, if you toss and turn at the time of bed, don't try to spend more than 30 minutes in bed before you kind of get up and take a little break from trying to sleep. Try getting up and reading for around 30 minutes. Milk actually has a precursor amino acid that can help create, basically it has tryptophan in it, and it actually can help synthesize melatonin, which helps us sleep. So try drinking some milk. Light matters at bedtime. So weirdly enough, there's actually been some interesting data into blue wavelength lights. So if you do get up, try to avoid your cell phone, your computer, anything that would have more blue wavelength lights. Now, if you're really intense into this, there's actually glasses you can get that will filter out blue wavelengths, so that's something to think about. Alcohol is something to avoid if you're having problems sleeping. It can actually reduce the amount of time that someone spends in REM cycle, and they've shown that REM actually has a lot to do with feeling rejuvenated after sleep. Sleep therapy in general, around 9% of patients had attempted this, and around 31% of patients felt that it was successful. Naps, in general, in the medical literature, there's a lot of mixed messages. Some say it best to not nap at least 4 hours before bedtime, and if you do, don't sleep over an hour, but do sleep at least less than 10 minutes. For me and my patients, I recommend, if you're dealing with a blood cancer, a nap is probably a really good thing, and if you're feeling really fatigued, it's probably because your body needs the rest. In general, we know that naps can actually help kind of reset the body and improve cognition. And they're very important for memory as well. Around 70% of people attempted that, and around 69% of people felt that it was successful. Another thing is trying to triage your day. And so triage is a medical term that sometimes we'll use, especially when people come into the emergency department to say, okay, how severe is this? But you can use it in your daily life to say, how important is this? Do I really have to go answer those emails now, or can they wait a couple hours? They say that 80% of what we do on a day-to-day basis will not significantly impact our life in 5 years. So I do have to say, if you have to focus on something, focus on that 20% that you think is going to have outcomes in 5 years. Consider setting priorities. And so we asked people if they did this. Around 75% of people do it. Around 75 or 72% felt that it was successful. Also postponing non-essential activities. Around 74% of patients had attempted this, and 63% felt that it was successful. One thing to think about is outsourcing. So if you have to clean the house, I mean, if you have the resources to do it, try to hire a cleaning company or maybe trade with a neighbor to do something for them. If you do have to do housework, try sitting down while you do it. Sometimes that can help a little bit with fatigue, do it a little bit slower. There's laundry pickup and delivery services these days. You can set up automatic bill pay. Try to order things online or hire a lawn care company. Overall, trying to balance rest and activity is a very good thing. So try to pace your activities. Around 58% of people had attempted this, 72% felt it was successful. Labor-saving devices. So around 39% of patients had attempted it, and 71% have felt that it was successful. And then scheduling activities that basically at times when you have peak energy, around 62% of patients had attempted this, and 75% felt that it was successful. The other thing is to use technology. So we have our smartphones these days that can really help make our lives more efficient. If you want to try and help triage things, making lists can sometimes really help, and then even being able to move things around on the list, and there's great apps to do that. I talked a little bit about labor-saving devices and different ways to get things, but here are actually, there's a couple, actually more than a couple, of different places that you can go online to get food delivered directly to your house here in LA. There's Deliver.com, Amazon Fresh, Google Shopping Express. Some of these are a little bit more affordable than others, but they're trying to make them more affordable. The other thing that I incorporated in my household that actually seems to help a bit is Alexa, and there's also Google Home. So I don't even have to get up and like turn on the lights if I don't want to. I just say, Alexa, turn on my lights, and it turns on. So it helps a little bit. Around 52% of patients had tried these interventions. Around 68% felt they were successful. Make time to be social. There's an energy about being around other people, and especially around people that know that you're going through and that can help you kind of figure out other ways to get around barriers that might be there, or just the camaraderie. But support groups, around 22% of patients had attempted, which actually I think is way too low, to be personally honest. But around 44% of them felt that it was successful. Volunteer activities can sometimes even help us feel better, and hopefully, if you're dealing with too much fatigue, I wouldn't recommend it. But there's different ways to volunteer, even sometimes just opting to be a part of like a phone call center. Around 32% of patients had attempted this, around 44% felt that it was successful. I'm going to go through quite a laundry list here. There are other things that can help with fatigue, potentially music, reading, spiritual activities such as going to church, mindfulness and relaxation training such as meditation or yoga, outdoor activities such as walking or gardening. So what about supplements? I will say there are quite a few supplements out there that are proposed to help with fatigue. B12 is important for blood production, and then actually I'll say out of every supplement I've seen, patients across the board, a lot of times will feel better with B12, and medically speaking, we're not sure exactly why that is sometimes, because they're not really been shown to have a B12 deficiency. Vitamin C is actually an antioxidant, and that sometimes will help patients feel better. Magnesium is important for nerve signaling, as well as muscle relaxation, and especially if you have a deficiency in magnesium, it's important to stay on top of that. Folic acid, again, is very important in blood production as well as neuronal development, so the neurons, or basically how nerves function. Caffeine can help, especially in the short term, to give you that extra boost. The only thing is it's a bit of catch-22 where sometimes too much caffeine will make you not sleep at night or can actually kind of use up your body's reserves, and then after the caffeine wears off, you're left more tired than you were to begin with. My general suggestion in the clinic is, as at all possible, try to increase the source of these nutrition sources through your normal diet rather than trying to take an extra supplement. So that means eating good, healthy food and trying to get a very diverse diet. What about prescription stimulants? So this includes things like methylphenidate and Provigil, which is a modafinil. These have definitely been used in clinical trial settings, and there's some data in different types of cancers that they can help with fatigue. But we recently did an analysis of patients in our group who had been on these drugs, and they actually, interestingly, had significantly higher rates of fatigue. So again, that could be the chicken or the egg, because they have higher rates of fatigue, which might be why they're being treated. Or it could be because these are actually causing kind of a paradoxical effect, and they're end up having less or more fatigue because of these agents. When should you be concerned? Well, call your doctor if you really just can't get out of bed in a 24-hour period, if you feel confused or unusually dizzy, if you're having problems waking up or problems catching your breath, if you feel that there's pain that's out of severe, or so severe it's out of normal proportions, or if your fatigue just can't get better no matter what, that's reason to call your doctor right away. And make sure that you talk to your doctor about fatigue, because there are very much, as I've kind of covered here, reversible causes of fatigue that should be addressed. Here's a good example as I saw just yesterday in my clinic. A patient who had come in was feeling more fatigued. He has polycythemia vera, and his blood count started to go down. And so we ended up, we did a bone marrow biopsy and checked some blood markers, and sure enough, he's B12 deficient. So I was seeing him back in follow-up yesterday, and his B12's come up, and he's feeling so much better. But there's definitely things we can do, and he hadn't transformed to MF, or myelofibrosis, thank goodness. Now I'm going to talk a little bit about gender differences in MPNs. So in general, there's actually basically the proportion of patients who are either male or female can actually vary by MPN subtype. So essential thrombocythemia tends to have more women in it. It's around some studies have actually suggested 2 women to every 1 man that's diagnosed. Whereas polycythemia vera actually tends to have more men. They think that men are anywhere between like 50 to 60% of the total population of PV patients. Whereas in general, myelofibrosis is thought to be equal among genders. This is not the only disease in cancer subtype, especially blood cancer, that tends to have certain higher frequencies in one gender or another. We know that for different diseases, including acute lymphoblastic leukemia, chronic lymphocytic leukemia, and even multiple myeloma tend to have different gender prevalences. Our symptom burden data has suggested that women are significantly more symptomatic than men for most symptoms that we've looked at. This is a marker where we've added all the symptoms together, and sure enough, it shows that women are more symptomatic. But then we looked into individual symptoms, and we were able to see that women have significantly worse, as I mentioned before, fatigue. They get full a lot faster. They have more abdominal pain and discomfort. They have worse headaches, concentration, dizziness, numbness, sleeping problems, sad mood, night sweats, and bone pain. Equal among both genders were problems with inactivity, sexual disturbance, cough, itching, fever, weight loss, and then just generally overall compromised quality of life. So you might say, well, why would symptoms be different among the 2 genders? And there's a lot of different things that we can kind of say go into the basket that funnels into our overall how we feel on a day-to-day basis, and things that can contribute to the gender differences that we see. Certainly for me, females, this can include things like pregnancy, hormone levels. You also can lump in blood loss with that, because women are much more likely to have blood loss, especially during years where they're still menstruating. We know that between men and women, there's epigenetic changes, as well as there's differences in the DNA. Men have the extra Y chromosome that females don't have. There's differences they think, in how the stem cells can function. And then certainly exposure history, lifestyle factors, and even the willingness to express the symptoms can be different between men and women. We know that hormones specifically, there's a lot of differences in the effects of estrogen versus testosterone. Estrogens tend to enhance the immune response and enhance how T cells function, but will also decrease the amount of basically hormones in the blood that will make your blood clot. Whereas men with the production of testosterone actually testosterone can decrease the immune response, as well as reduce down some of the hormones that will basically help to prevent the blood from clotting, making them a little bit more likely to have a blood clot, at least from the markers that they see. So in terms of sexual dysfunction, this is a broad term. It can deal with issues and problems with sexual response, desire, orgasm, or even pain. There can be complications, including, it's a complicated process that includes neurologic, vascular, and endocrine systems. So there's a lot of different things at play. In terms of why sexual dysfunction happens, you can get fatigue that we've talked about. You can get, again, anxiety, depression playing in. Medications can play in, steroids, antidepressants. Antidepressants are notoriously things that actually can impact sexual functioning. Endocrine issues, anatomical issues, things like a very large spleen can make it very uncomfortable to basically participate in sexual activity. And then interpersonal issues. You may just not feel attractive when you have a giant spleen, and these are things that you'd have to kind of, you should be aware of and try to work through, especially with your partner, and feeling attractive to them and them feeling attractive to you. It's a very complicated process. We know that 64% of patients reported sexual dysfunction, and that around 40% of them said that this was severe. And then we looked at healthy controls. This is significantly higher in our population. These sexual difficulties also were highly correlated with reduced quality of life, sad mood, problems sleeping, inactivity, cognitive problems, and dizziness. So what to do about sexual dysfunction for women? Number one, talk to your physician again. They should be doing a physical exam. There's different things that they should be looking for. Give you an example, if it's very painful, they should be looking to see, we know that for polycythemia vera and myelofibrosis, sometimes you can be at increased risk of viral infections, and sometimes that can actually manifest and cause it to be painful to be intimate with someone. Your physician should also check your blood counts. If you're very anemic, it's going to be hard to walk, nevertheless, to participate in sexual activity. They can also check endocrine levels. A good example would be in men with a testosterone deficiency. That can really reduce someone's desire to be in a sexual relationship. Talking with a counselor or close friends, especially if you're feeling depressed or unattractive, they can also really help to address interpersonal issues that are going on, as well as psychological barriers, things like anxiety, depression. In terms of other things that just generally could be recommended if you are experiencing sexual dysfunction, so trying to spice things up, make things out of the routine, enhancing stimulation can sometimes help. And you have to think intimacy, sexual function, intimacy is very complicated. It means more than just intercourse itself. So there's different activities that you can do that are not necessarily having sex with someone that would still be very intimate. Try what you can to minimize discomfort or pain. It's amazing what a little bit of lube can sometimes do. And then most of all, just enjoy the moment. The most important thing is, I think, for this everyone here is to, again, get and stay connected. There's wonderful community resources here in the LA area, such as Cancer Connection. There's the Leukemia and Lymphoma Society branch, the Cancer Support Community here, at the Benjamin Center, which as I learned before, that is a really great resource. They have support groups there. There's the Los Angeles Cancer Network. And then, of course, we have our MPN groups that are just wonderful. So, the MPN Advocacy and Education Foundation today, MPN Research Foundation for Michelle, who you heard from earlier, MPN Voice and MPN Forum are online resources. And there's strength in networking and helping to do even your part to help us be able to make your prognosis better. So I'd like to thank especially Dr. Robyn Mesa, who's my mentor and close friend, Dr. Angela Fleischman, I've worked very closely with here, and she's in the LA area. And I'd like to give a little bit of a shout out to Dr. Geyer, who couldn't be with us here today, as she is moving along in her own pregnancy and dealing with her own reproductive issues, but also very soon might make me into an aunt. So very excited.